So let's turn now to Quizartinib. Quizartinib is also a second-generation drug, more specific than the first generation, but it's a type 2 inhibitor that actually maintains the inactive conformation of the enzyme, but unfortunately the TKD actually favors the active conformation, so TKDs are not susceptible to Quizartinib. On the other hand, as I remember your presentation and publication of the phase 1 data with Quizartinib in patients with low allelic burden of FLT3, there was still activity of Quizartinib there as well. But tell us about how Quizartinib is being assessed in this population.
Yeah, so yeah, I mean, as you mentioned, this is a drug that has been under development for a few years, and it's gone through different steps, including the identification of the proper dose, because the initial phase 1 study suggested an MTD of 200 milligrams daily. And then after we went to phase 2, we quickly realized that was too much, mostly because the DLT has been QTc prolongation. So from there were a couple of studies that brought us down to the dose of the 30 to 60 milligrams daily. And the efficacy was very good, very sustained across all these different doses. So we didn't lose anything in terms of, certainly not in terms of CRs and CRIs, across these different doses, but the incidence of QTc prolongation dropped dramatically from, with 200 in the phase 2, we saw about 90% of patients with that prolongation, and that went down to single digits when we did the lower doses. So these lower doses were the ones that were taken to a randomized study called the Quantum R study that was presented last year at EHA. Was the first time we presented the data, and the design is very similar to the Admiral study that Sasha mentioned. A few differences. The patients were again refractory relapsed AML. They all had to have FLT3. Only FLT3 ITD was eligible for this study because of the type 2 nature of this inhibitor. It was patients should have received intensive chemotherapy and anthracycline-containing regimen. They were not eligible if they only had hypomethylating agent or something like that. And if they had a relapse, they had to have relapse within 6 months. They were randomized 2-to-1 to receive Quizartinib, and the way the Quizartinib was administered is to start with 30 milligrams for 2 weeks if the QTc remained within acceptable limits for 80 or less. Then they would escalate to 60 milligrams and then continued uninterrupted until progression. For the patients who were randomized to the control arm, they could get one of 3 salvage therapies, pretty much the same. The 2 intensive were again FLAG and MEC. The non-intensive was low-dose RLC. There was no hypomethylating agent control here. And they would, they would receive that as per standard therapy. Patients could receive a transplant, and patients who were transplanted, if they were on Quizartinib, they could go back to Quizartinib. The selection of the control specific therapy, just the same, was selected prior to randomization. You had to decide which one you would use if the patient was selected. The primary endpoint was overall survival, and the primary endpoint was met. There was a hazard ratio of 0.76. There was a significant improvement in overall survival. The median survival was prolonged. The 1-year survival was improved. The response rate, which was a secondary endpoint, CRs and CRIs, what was called the composite CR rate, was significantly better. Was almost 50% with the combination with the Quizartinib. The majority of the responses were CRIs. There were just 5 or 6% of the CRs. Most of them were actually CRIs. There was an improvement in transfusion requirements. There was a post-hoc analysis, but we found that about 30% of patients became transfusion independent. Event-free survival was also improved. So overall, all these, and the rate of transplantation, again, knowing that this is not, as Sasha mentioned, the end of FLT3 relapse, so getting them to transplant in this setting would still be what we would like to do. over 30% of patients were able to go to a transplant, which was much better than what we got with the chemotherapy, just reflecting the difference in the response rate, as you can imagine. In terms of safety, it was fairly safe. The main adverse events that were seen more frequently with quizartinib were one, QTc prolongation, although the grade 3 incidence was only 3%. So certainly, again, this dose was very safe in that regard. And the other one, also some instances of these differentiation syndromes. So that's something that you need to be aware with these drugs, that we do see these instances. Other than that, a fairly safe drug. But there was one of the other differences. Quizartinib is very potent, perhaps even a little bit more potent than gilteritinib against FLT3, but it also affects c-KIT. And there's been a debate whether that may be the reason why we see more CRIs and CRs or even CRHs with quizartinib than with, for example, gilteritinib. You see the c-KIT inhibition that's making more prolonged myelosuppression. So there was a little bit more of that. But overall, another very effective drug that essentially does the same thing in a very effective and safe way, oral, outpatient, very good.
So on your study, about a quarter of the patients who were randomized to get chemotherapy ended up coming off study, and that wasn't true on the quizartinib. Any idea of what those patients went on to get?
There were about 20%. There were some in the Admiral. There were not as many.
Well. I think it was a lower number,
15%,
though. Yeah, about
12%, something like that. So there were some, and of course, what happened is by the time this study started, we had sorafenib, and there were other studies. So a lot of the physicians or the patients decided, you know what, I want a FLT3 inhibitor by now, because these patients had not been exposed to a FLT3 inhibitor for the most part. And we went back to look at the data, and we were not able to collect the data in all of them. But sure enough, many of them went on to receive a FLT3 inhibitor. And others received the same standard chemotherapy, but they said, if I'm going to get standard chemotherapy, I'm not going to do it in the study because it's more restrictive. A study makes you more visits and whatever. So